Hello, students. Welcome to Blood Dyscrasias. I hope you've watched the blood basics first so that this will not go into the basics, but we'll just talk about the illnesses. So anemia can be quite overwhelming and comprehensive and affect many systems in the body, of course. You can get yellowing of the eyes and the skin because of improper, particularly with hemolytic anemias, where red blood cells are targeted and break down prematurely and often causing buildup of bile or hemosiderin in the sclera and in the subcutaneous tissue, most commonly seen in patients with chronic renal failure, that sort of yellow or sallow color of their skin. They can often feel cool. Of course, that's one of the presenting signs and symptoms of iron deficiency anemia. They can often look pale. They develop shortness of breath as oxygen delivery is thwarted. Muscular weakness. If acute, the hemoglobin and hematocrit drop, they can certainly start to feel fatigued, dizzy, and fainting. Fainting is not often commonly associated with many anemias, but certainly could be with acute blood loss as a result of hemorrhage. Tachycardia, palpitations, chest pain, we'll talk about that. That's one of the presenting signs with sickle cell. And certainly the spleen can become enlarged, although not here on the list, but sometimes also the liver can become enlarged. So there's three types of anemia. And most importantly, anemia now may take on a new form for you in this advanced patho course. It's not really the number of RBCs, because you may have functioning, or you may have plenty of red blood cells, but they're not functioning. The hemoglobin is not functioning, generally speaking. So anemia is truly classified as ineffective oxygen transport in the blood, usually attributed to loss of hemoglobin. So that's an important concept, particularly as we look at things like pernicious anemia, where you've got plenty of red blood cells, you've got big old red blood cells, but that hemoglobin is ineffective, so it can't carry the oxygen in the blood. So three ways in which we face anemia can be either hemorrhagic, as with an acute blood loss. You can have hypoproliferative diseases, where the bone marrow just dysfunctions and does not produce the necessary red blood cells. And you can have hemolytic anemias, where the body has usually autoimmune or drug-induced illnesses cause the premature breakdown of erythrocytes. I'm not going to spend a lot of time with bleeding, because I think if you pass the NCLEX, most nurses are quite versed in hemorrhage and the hypotension associated with that. But I will say, as new knowledge might be for you, that whenever you do have an acute hemorrhage or bleeding of an acute onset, you will note an acute rise in the reticular count. We talked about reticular counts in the basics slides, right? Excuse me. Reticulocytes are immature red blood cells that are produced in the case of bleeding. So we talked about the normal red blood cells in the blood basics slides. And today we'll talk about iron deficiency anemia as an example of a microcytic hypochromic anemia. We'll talk about pernicious anemia as a megaloblastic anemia, a big cell, a large cell, macrocytic. And we'll talk about sickle cell disease and a few other anemias. So first, the hypoproliferatives. These are usually due to some sort of a nutritional deficiency. I think most nurses are familiar with iron deficiency anemia. Most often who succumbs to this are people with women, particularly who have large losses of blood due to menses, bleeding ulcers, chronic gastritis, inflammatory bowel disease, chronic alcoholism can contribute to it, and just malabsorption, maybe perhaps from celiac disease. Also, patients who have had partial gastrectomies. So they may have some of the the signs and symptoms associated with anemia, which I'll show you in a few minutes. Glossitis and these spoon-ridged nails. So one of the things you look for in iron deficiency anemia is check the iron levels in the blood, check the MCV. Usually it's less than 80. Check the hematocrit, hemoglobin. Encourage your patients to eat more dietary sources of iron. But here's the main diagnosis for iron deficiency anemia is usually a low hematocrit. It's a classic definition of microcytic IDA is that the MCV is below 80 and that the MCHC, or the mean corpuscular hemoglobin count, will reflect a pale cell, hypochromatic, due to the lack of hemoglobin on the red blood cell. And the percentage of hemoglobin on the cell, or the MCH, will also be low. And in this case, you'd send off a peripheral smear where you just look at the nature of all the blood cells to look for any unusually shaped cells. But if they're purely microcytic, round, or biconcave, right, concave, non-sickled, if they're just the general size and shape morphology, but they're just pale and small, then you've got a clear definition of iron deficiency anemia. Then, of course, you can send off iron levels to document it. There's also, we talked, or I didn't talk, but in the past slide set, I talked about elevated total iron binding capacity. Normally, you have iron, your normal is 240 to 450. But when you have low iron in your blood, the capacity goes high low, because you don't have enough hemoglobin to attach, right, to those sites. So in this case, the total iron binding capacity would be low because there's plenty of receptor sites for hemoglobin to bind. You'd also look for low serum ferritin levels as well. And they classically have, of course, this is chronic in nature, the spoon-shaped nails on, as you can see on the left-hand side versus the normal structured nail there. Not sure exactly why it takes on this spoon shape, to be honest, but it does. And then the glossitis, the red beefy tongue, and classic angular stomatitis, cracks at the corners of the mouth. So with these patients, obviously just check their labs, encourage them to eat more spinach or more iron in their diet. And of course, we have many vast array of supplements, ferrous sulfate, ferrous gluconate, and others to manage this. And if they're having problems, treat the structural problems as well. If it's menses, maybe they need a GYN consult. Look at the structural problems as well. I don't have a lot of information here on anemia of chronic disease, but anemia of chronic disease sort of does mimic iron deficiency anemia. And this is oftentimes you'll see a patient just have a low hemoglobin and hematocrit, and you don't know really why. It can often be, look to see if they have a chronic illness as well, because oftentimes when patients are chronically ill for a long period of time, the body does not concentrate its efforts on homeostasis. So they just might not be producing enough erythrocytes at this point in time because the body's stressed from other chronic diseases. So again, in this case, with anemia of chronic disease, and McCants does talk about this, it's important to treat the chronic disease, and then maybe you can get the anemia under fixed as well. So hemolytic anemias, usually autoimmune. The body attacks the erythrocytes. Drugs can cause this. And there's a chart with all of the various illnesses that are causes of hemolytic anemias on chart number 29.6. Most notably, penicillin, cephalosporins, and Bactrim can cause hemolytic anemias. Now, pernicious anemia Again, this is I don't know how that got in there. I'm sorry. This is hypoproliferative diseases, not hemolytic, right? Pernicious anemia is due to a loss of the intrinsic factor by the parietal cells in your stomach. And when you have loss of the intrinsic factor, you cannot absorb vitamin B12. And it also needs to be packaged up, the combination of B12 and the intrinsic factor, in the ileum. So patients who have lost part of their stomach or part of their small intestine are at high risk for pernicious anemia and need replacement. Pernicious anemia or vitamin B12 anemia, generally, unless a person has just had gastrectomy, generally develops over years. Patients are usually not symptomatic until the hemoglobin reaches 7 to 8, which is just amazing when you think about that. Patients with pernicious anemia may develop that smooth, sore red tongue I told you about. They may also, there's a neurological component to this disease if left untreated. They will lose their decreased position and balance because vitamin B12 is necessary for myelin production, not only RBC maturation, but myelin production. So you can oftentimes sort of sort out vitamin B deficiency and folate deficiency because vitamin B12 often has more neurological manifestations than folate deficiency does. So it's important to look for paresthesias, a decreased ability to sense decreased sensation in their lower limbs, and a decreased awareness of position and balance. Here with vitamin B12, the MCV is large. It's greater than 100. So that's classic for vitamin B12 deficiency. And here they have what I call big bully cells. They've got plenty of red blood cells, but they're just big bully cells. They take up a lot of space, but they don't do anything because they just don't hold the hemoglobin. So again, just do a neurological assessment. I'd look at their gait. I would look at their take the tuning fork and see if they can sense the tuning fork at the distal from their knee, and vitamin B12, either IM or PO. Folic acid deficiency. Again, you need the body needs to be totally. The only way you get folate is through your diet. So there's an increased need in pregnancy and lactation, and most women of child rearing age should really be taking folic acid deficiency, if at all, chance of pregnancy, because 50% of pregnancies happen are not planned. So therefore, folic acid is so important for the embryo's neurological development that it's absolutely critical that they take it if they're at all thinking about having a child. Folic acid deficiency is very common in alcoholics, more common than pernicious anemia. And folic acid is an essential element required for DNA synthesis and red blood cell maturation. So again, it's a big cell. Again, the cells are large. The MCV is greater than 100, and it's a megaloblastic anemia. And you test for it by just sending a serum folate test. And again, you can replace it with folic acid, 1,000 micrograms a day. Sickle cell anemia is there are 4 molecules, right, of proteins of hemoglobin attached to an erythrocyte, and for some reason, genetically inclined patients, that hemoglobin is defective. So what it does is it becomes stiff, and it sort of pulls in the red blood cells to that classic sickle or crescent moon shape. And then this classic sickle cell shape becomes obstructed in the I think I have a picture on the next slide, in the arteries, which causes ischemic crises in these patients, which can lead to tissue necrosis and quite a lot of pain. It's primarily from people from Africa, or those that have emigrated from Africa in past generations. Like I think of Dr. Ledger has done a lot of work with sickle cell in clients in Jamaica that had originally from other generations migrated over from Africa. So again, here's a picture of the classic sickling that causes occlusion in an artery, which leads to the ischemic crises that these patients succumb to. And so you can see that they can actually develop cardiomegaly, chest pain, tachycardia, jaundice from the premature breakdown of these cells, ischemic leg ulcers, etc. So get a blood smear and you'll see the classic sickling, low red blood cell counts. They may have elevated WBC because of some ischemic and inflammatory processes occurring. And obviously you'll just look for the presence of those sickled cells. There's no cure for this, unfortunately. It's symptomatic management. Try to avoid things that cause triggers for these folks, such as secondary illness, cold exposure, high altitudes like flying can be very can cause crises in these folks. Stress, overexertion, acidosis are some of the main triggers for sickle cell crisis. We talked already about polycythemia vera. This is where the bone marrow produces excessive erythrocytes. So we talked about this with cancer. So I just want you to review that. All right, these patients are at high risk for increased coagulation, coagulopathies, which can cause clotting disorders, which can lead to stroke, MI, PE, etc. Bottom line management of anemias is to correct and control the cause. As with many of these, they're due to poor diet, right, or alcohol abuse. So proper screening, then remove the causative agents. Obviously, try to stop ingestion of alcohol if possible, and replacement therapies. We're not talking about leukocytes today because we already actually talked about those at another time. We should talk briefly about platelets. Platelets or otherwise known as thrombocytes, are not actual cells. They're just fragments of cells called megaloblasts. And of course, as you know, they control bleeding. So just review thrombocytopenia and thrombocythemia, which is an overproduction of platelets, which we also talked about with cancer in the cancer lecture. And then there's this idiopathic thrombocytopenic purpura, which is often drug-induced, and we're going to talk about that again in a couple of minutes. So I'm sure you know what thrombocytopenia is. I'm going to ask you in McCants to read about heparin-induced thrombocytopenia, because that's very common, and so you should be aware of that. You should know the difference between purpura and petechiae. Petechiae are the ones that you can see up here closer to the ankle bone, those little discrete nodules, and purpura is what's sort of lining the near sole. They're amassed. They're petechiae that are amassed into like one sort of area of redness. Very common with ITP and thrombocytopenia. So again, idiopathic thrombocytopenia purpura, very autoimmune, generally speaking. The antibodies attack the platelets, and it causes early destruction of platelets, so they end up with this thrombocytopenia. Very, very acute, so you should be able to identify it. G6PD is not a very common anemia. It's an X-linked disorder. It usually occurs in African American men, but there's a certain classic, and you'll learn it in pharmacology, so you should be aware of this, that there's a certain class, there's a list of drugs that you would not want to give to somebody with G6PD because it will cause an anemic crisis. So G6PD is an enzyme that actually protects red blood cells from chemical radicals that would be formed if you were to give them any drug off that list. So it's deficiency of this enzyme that causes the anemia. And if you did give them one of those drugs on the list, it would cause an acute hemolytic anemia. So you would really rather not. You just should be aware of G6PD if you're caring for African American men. And there's a list of the drugs. There's more, but those are the most common ones. Review hemophilia. It's a very complex disease, and you're not likely to be managing that as an NP. I think it's suffice to know that there are two types of hemophilia. There's a deficiency of factor VIII, and then there's hemophilia B, which is the deficiency of factor IX. Yes. So you saw a video earlier on clotting cascade, so you can see the effects of hemophilia A, hemophilia B. As a result, of course, as you know, they have difficulty clotting and they tend to bleed. They have a prolonged, we didn't talk about those, prolonged PTT. We'll have to talk about those when we talk about DVTs later on this semester. And of course, the treatment is the replacement of the factor VIII and factor IX. So, review clotting abnormalities, vitamin K deficiency. I think most nurses know about that. I asked you to think about, please read in McCants on heparin-induced thrombocytopenia because it's very common. Other anemias, we talked about aplastic anemia and polycythemia vera in cancer lecture, so do review those. And if you have time and energy, you won't see much of this, but you should be familiar with thalassemia and hemochromatosis. These are cases where you could actually initiate an iron overload, which is really bad in these patients. But again, not so common. So I'm not going to dwell on these in a podcast, but you can read about them in McCants. So thank you very much, and I'll see you in class soon. Bye now.